Welcome to The Waiting Room. I'm Dr. Raj Laly, and this is a new podcast that's going to be talking everything about healthcare, particularly in the UK. The first guest that I'm going to talk to is Aisa Fraser, who's someone I've known for a number of years, that's been involved in many projects, whether in the UK, outside the UK, all to do with healthcare and things surrounding it. Hi Aisa. So you have joined me on The Waiting Room, the first person on the podcast.
Thank you for having me. Very exciting.
Yeah. I think you were saying to me off air that I don't often ask you questions, so this is an opportunity for that. So thanks for being the first guest.
Thanks for having me.
Tell me a bit about yourself. Tell the listeners and viewers about yourself.
Where do I start? So I was born in Portsmouth. I did a bit of primary school in this country and then ended up in New Zealand. My dad's actually Fijian, so huge Polynesian family out there. Really begrudgingly came back to the UK just in time to do GCSEs that I'd never studied for, so thanks to my parents for that. So I did my A-levels here and then studied nursing in Southampton, obviously not bright enough to be a doctor. My dad is was a broadcaster, so I think probably had sort of more exposure to current affairs and those sorts of things growing up as a child. So really sort of interested in the world and had some really great exposure to things like apartheid and even fascinated randomly by things like the Rwandan genocide. So really looked at the kind of humanitarian aspect of how I could start my nursing career, which was a reason that I went into nursing. So studied down in Southampton, which was brilliant, and my first elective I did in South Africa on a healthcare train, so really sort of solidified my desire to work in the humanitarian world. When I came back and decided to get my first job up in Scotland, so working in Edinburgh, which I think was quite good training for the war. Really fascinating city, really great fun. I was there for 4 years in both sort of medical assessment and emergency. And then, whilst I was there, decided to explore how I could work in the humanitarian world. So, studied tropical medicine down in London part-time and got my tropical nursing diploma. And on my last day, interviewed with Médecins Sans Frontières and ended up working abroad.
That's quite a list so far. I know you've done a lot more after that.
Yeah.
I mean, interesting. I mean, sorry to sort of just butt in a little bit there. So it's interesting. So I didn't know your dad was a broadcaster.
Yeah.
In terms of doing things abroad, humanitarian bits, do you think that sort of upbringing with your father and what he was interested in had a bearing on you as well, in terms of what you grew some interest into, and I think you also do now?
Yeah, definitely. So he's a Polynesian Fijian, so he's brown. He has our family photo looks like the United Colours of Benetton. We've got he's one of 12, and we had a really diverse just our family alone. He's was a very gregarious chap, and even in sort of middle class rural Britain, every so often he'd have a Zimbabwean friend that we'd be wandering through the village with. So I think his natural curiosity for people sort of wore off for me, I think, as well. And as I say, the dialogue at home of current affairs and what was going on in the world, I don't necessarily think my friends were having those debates about how terrible the apartheid regime was in the 80s and those sorts of things, but it was something that I really vividly remember, and thinking just almost in a kind of voyeuristic way, like how unbelievably insane it was that we were watching these sort of crises unfold, like the Rwandan genocide, and just almost sort of glued to the TV watching it unfold and not doing anything about it. So as I say, it's sort of probably genuinely one of the reasons I wanted to go into nursing was because of that as a background.
Okay. And then going into things that you've done in the humanitarian sort of world, where you've sort of have done things abroad, I mean, what stands out for you in that, on that side of things? I know you've been to sort of dangerous places, weird and wonderful places, but also, it brings in a lot of emotion and challenging elements there. I mean, what things stand out for you in that? Yeah,
it was interesting because I remember having a conversation early on with a matron in the Edinburgh Royal Infirmary. Quite early on in my career, I was probably 3 or 4 years in, and I remember saying to her, this is, I think I was applying for study leave to go and do my tropical nursing. She was very adamant I shouldn't be going because I hadn't quite solidified my skills. You know, she felt I was too early on in my journey. Working with them, particularly where we were, Médecins Sans Frontières, I think I went straight to, well, I did go straight to Sudan, which was, you know, very, very remote. But the skills that I acquired clinically were, you know, uncontestable. They were just unbelievable. Looking after a load of children that had dismantled a rocket-propelled grenade and eaten the C4 within. You know, delivering babies, all under the registration of the NMC. So I had a UK contract. So it's, you know, it's considered, I don't say legitimate, but it's not third world medicine. It's bush medicine, but with incredible mentors and those kind of things. But not only did I acquire these amazing clinical skills, the things that I learned about things like financial responsibility, accountability. So I don't know how much you know, but Médecins Sans Frontières provided, all of their donors are private. So there's no sort of government affiliation. So every penny has to be sort of traceable back, and they're really keen to talk about transparency and those sorts of things. So that kind of financial conscience, how you're, as I say, being accountable for every penny that's being spent, but also things like you're living in really remote environments, often with sort of 10, 12 other international staff, and then lots and lots of local staff with very, very varied skill set. So it makes you, sort of really understand yourself as a person and how you can adapt to, you know, being in the middle of nowhere with in a challenging circumstance, but also how to adapt your human resource processes in order to make sure that you're getting the best out of people and supporting people in proper adversity.
Do you miss that world? Because obviously you're not in that now. Or are you in a different place in life and less so?
Yeah, I mean, it's an interesting question. So one of the, it was a little while, quite a while ago that I was working with Médecins Sans Frontières. I finished in 2011. So things have changed for that organisation as well. But one of the things that really I felt really passionately about was how decent and strong their processes were, but also how, in some ways, a lot of their bureaucracy was a lot less heavy than we know in NHS world, for example. So I think one of the things it really taught me was about managing risk and assessing risk in a way that wasn't necessarily thinking about defensive medicine, for example, or wasn't necessarily thinking about ticking boxes and sort of, as we know, the sort of bureaucracy that goes with supply chain in this country. It meant you were accountable, but you weren't having to jump through a lot of hoops to get things done. And because it was such an acute environment, your focus had to be on people and had to be on clinical management rather than, as I say, sort of what I feel is often heavy, superfluous process.
Yeah. Okay. No, that is really interesting. And also what I find interesting is how you got into that, and possibly the background with your sort of father, family, in getting into that. So obviously, when you were doing the humanitarian stuff and the charitable element, how did you eventually go from that and sort of transition back to the UK and sort of getting involved with sort of healthcare bits here?
Yeah, again, another really interesting point. So MSF are really good at sort of the preparation and managing expectations going into that kind of environment, probably a bit like the military in some ways. So you end up in very sort of remote corners. I was in Sudan. I worked in the Democratic Republic of Congo, which is currently under siege at the moment. I was in and out of Kenya a lot, and working with people from all over the place. The sort of more experience you gather and the more languages you gather and the more time you spend with the organisation, I think you sort of end up in more and more bonkers places. And it got to a certain point as a woman that I wanted to have a family of my own. I was actually on my way to a civil war in Côte d'Ivoire when my GP at the time, Andy Kent, suggested maybe you might want to make a different decision. Because I was asking him for malaria tablets and he was like, you can get pregnant, aren't you? I was like, oh yes, probably not the best place to go. Yeah. So it was basically about starting a family, but it was it was the hugest transition I'd ever made. So I've been living in essentially conflict zones in East or Central Africa with a handful of other international staff. And then, yes, settling down with somebody I've been with on and off for a very long time, but having to live with a boy in the affluent area of Petersfield. So it was quite something.
So that's quite a change from going through places which are dangerous, and you obviously get the adrenaline element of dealing with sort of creating sudden projects and a lot of autonomy to suddenly being in leafy but nice Petersfield, but suddenly it's a complete change of environment. How was that?
Yeah, I mean, it was the hardest transition of my life, and sort of reflecting, it was sort of, I was decompressing from all of the traumatic experiences that we'd incurred along the way, but also transitioning into motherhood and also the complete opposite end of the spectrum in terms of affluence and need and those sorts of things. So it was a tough, particularly first year. Andy Cairns was formerly my GP, but also a bit of a sort of mentor in things like when I was a student nurse and those sorts of things. And he was a senior partner in Petersfield, so he'd sort of said at the time, if ever you want to come back and explore working in general practice, then do. And actually it suited me in terms of where I was with my children and my family and those sorts of things, but it couldn't have been more different. It was, he could tell you it was quite a bumpy ride for a few years, which is obviously where we met.
Yeah, I think I recall. I think I was, I don't know, I might have a blood sample or something that was bagging up in reception, and maybe you turned up and you might have been on maternity leave and you're like, who are you?
I think it was quite an
open sort of semi-aggressive sort of like, what are you doing here type thing. I think I introduced myself and you sort of said okay and then just walked off.
Carry on.
So
again there was a lot, quite a steep learning curve. I did a year I think before I went on maternity leave with another child as a practice nurse, so learning all your childhood immunisations and women's health, smear clinics and those sorts of things. But it was an interesting time in general practice, because I think funding at that point, I think that might have been when the slow truck started turning, because we were looking at merging with other general practices in a bid for survival, I suppose. And I was the idea was floated for me to come back from maternity leave as nurse supervisor, which at the time I had colleagues that were really well established. They'd been in general practice, but particularly in that general practice, or that practice itself, for many a year. So to have somebody who'd been sort of in bush medicine and hadn't been around for a very long time, it was quite a challenge in itself to win the hearts and minds, as they say. One of the things that I think I saw, and it felt almost visual, was just the disparity between general practitioners, so the GP doctors themselves, and the nursing team. And that was anything from the representation on the walls of pictures of doctors and the nursing team not being there. There were these lovely lunches that GPs had these meetings in, and nurses weren't necessarily there. So I felt quite passionately, probably, again, coming from MSF, where hierarchy had been a bit more horizontal or flat. So yes, wanted to chip away at that a little bit. So I think I did that. I sort of wanted to bring the nurse team into the 21st, bring the GPs into the 21st century, and ensure that both healthcare professionals are working, sets of healthcare professionals are working together and representing each other's needs.
Yeah, I mean, personally, that's something I never understand, is the hierarchical element that you get in healthcare. But I suppose it's all traditional, what's happened historically. So breaking those barriers are really quite important. And I know you do a lot of that, which is good. So in terms of things that you have done in general practice, or a little bit beyond that, what sort of projects have you got involved in that you found really interesting and passionate about? Once you were obviously sort of fully here back in the NHS and things, because I know you sort of go and dive into lots of things, and what things really stand out for you. Yeah,
so I think when I was at Swan Surgery in Petersfield, one of the projects that I really enjoyed was looking at our wound care. It's very glamorous, but our wound care healing rates. So we had these leg ulcer clinics where patients would come in and we'd see them for months and months and months, but we weren't necessarily challenging why they weren't healing. So we got involved with a really skilled tissue viability nurse and just got some passion going within the nursing team. So managed to reduce a lot of those rates with just better evidence-based practice, really. And that, I think, had a rippling effect for other services within practice. Sort of after that, so after I left, I sort of helped the surgery merge a couple of times, and just sort of felt I'd reached the end of my skill set in terms of anything I could do at general practice level. So as you know, left with a plan of having a couple of weeks off and nothing much more, and then GP Federation. So what's that? 40 practices at the time.
Yeah, fair few.
By which point you were a director?
I believe so. Yeah. So obviously, with the going into the alliance world, myself, I ended up being a director there. But for yourself, so obviously leaving sort of general practice and then going into the GP alliance, or sort of people know them as sort of federation world. How did you find that? Because again, that's a little bit of a transition. So obviously, where you're in general practice, you again can have sort of decision-making bits that you can do and sort of influence quite quickly. But then you're in a new organisation. You're probably overseeing more practices and sort of different type of contracts. So how did you find that from your personal perspective, but also that job satisfaction element?
Yeah, so my first role with the Alliance was a sort of transitional role really, so it's sort of 8 weeks worth of CQC readiness, so compliance world. And it was fascinating for two reasons. One, it was getting into the nitty gritty of CQC, so our compliance stuff. But also, I couldn't believe how much I could achieve if I didn't have patients or I didn't have people to line manage, which sort of reflects my thoughts on process and bureaucracy. But it was a really interesting exercise because it made me look behind the scenes at every clinical process, at our human resource management, all of those sorts of things. And then I interviewed for a role as head of clinical services, which I don't know how much people know about GP federations, but they're essentially sort of, ours was about 40 practices sort of clubbed together for larger contracts, wasn't it? So at a certain point, I think we supported out-of-hours hubs, so that's when people are phoning outside of traditional GP hours and needing access to healthcare.
And this is southeast of Hampshire?
Yeah, southeast Hants, Fareham and Gosport it was at the time. I supported the implementation of the 111 contract, so that's for patients phoning up 111, needing support, again, predominantly outside of working hours, but traditional hours, but also GP. And again, what was really interesting was sort of tapping into my skills, networking and those sorts of things, probably because of curiosity and just because I like people. It was interesting forming some of the links with other sort of practices, some of the lead partners, some of the practice managers, those sorts of things. Not always necessarily positive experiences, but from a learning point of view, it's always very interesting. And then obviously we had at a certain point, not particularly long after we joined, we were hit with the global pandemic. And that was a really frustrating time for me, having spent a lot of my professional life learning these specific skills to manage epidemics, to be faced with a global pandemic and what felt like quite a lot of people above, not necessarily with the right skill set, an awful lot of indecision, and again just no direction, but equally no ability to listen to sort of the groundsmen who might be able to support. So
obviously the COVID pandemic happened, which obviously everyone was a part of, whether you're in healthcare or not. And you were in the Alliance at this time in Southeast Hampshire, how did you find that? I mean, how did you find it personally? Because obviously, I know it was a busy time for you. And also, how did you find it system-wise in terms of lots of things that you were involved in for it? Because I know there were multiple things that you were fully involved in that was having huge benefits in terms of healthcare and how we were managing healthcare.
Yeah, I mean, there was a certain time right at the start where I was like, this is my moment, but I'm equipped, as an individual, I've spent a lot of time working towards being able to professionally manage the situation. What I wasn't prepared for was the stuff above me that was going to stop me from being able to flex my skills. So quite often I was having to do things and then ask for forgiveness later. Quite often I didn't get that forgiveness. There was a time that we recognised, and it was again a project I was particularly proud of, recognised that one of the things that was happening with COVID was people's oxygen levels were particularly compromised, and they didn't necessarily need to be in a hospital for measuring those, and they particularly couldn't be because hospitals were so overcrowded. They didn't need to be going in and out of GPs practices and spreading the virus, but we could manage them in their own homes. So we set up a virtual ward, and at the same time we set up COVID red hubs, so assessment in the community to stop going into hospital. But the COVID oximetry at home ward, where we were measuring patients, we were sending out oxygen samples, we set up a whole process and set up these wards more or less overnight. I think we managed to staff, there's suddenly a surplus of people, and again, because bureaucracy had been cut a bit, we managed to, rate and pull in loads and loads of really good people that could just help us manage this patient load. At the time, I think, like at its worst, we had 60 patients on the virtual ward, and our conveyance rate to hospital was about 25% before vaccinations started happening. So that's a lot of people, there's a lot of ambulances going out. So to be able to monitor that number of people in the community, if you think about what the burden could have looked like in hospital, was...
And to remind, so the virtual sort of COVID wards were where patients had COVID as a diagnosis, and you were monitoring their oxygen levels.
That's right, just with a simple bit of kit. And I think you and I had even had a conversation before it became a national thing. It felt like we were, again, ahead of the curve. It was sort of like, if we can just make sure that we know what people's oxygen levels are and stop them from getting to a dangerously low point, then we know that we can keep people alive.
Yeah.
And I think we'd had that conversation a week or two before, and then all of a sudden these oxygen clips arrived for people's fingers. So it was as simple as making sure that we had somewhere central that people could come and collect these from, somebody who didn't have the virus, take them home to a relative or drop them through to a letterbox.
And then escalating into hospital.
And escalating, yes. We had a team of people at our hub that were amazing, so they'd just phone 4 times a day to see what the oxygen levels were. And quite often, there'd be other things that going on at the same time that we'd pick up. But also sort of, I think people were really scared at that time. And I know that the first person that was on our virtual ward, and he's often reflected back how enjoyable it was to suddenly have those conversations on a daily basis while he felt like he was going to cark it at home.
And what we forget, obviously, because the pandemic now seems a while ago, was knowing that you had that COVID diagnosis at that time, especially if you weren't vaccinated, was clearly a big thing, wasn't it?
Yeah.
So rather, whilst it was obviously managing the oxygen, there was a lot of the talking to the patient and managing the emotional aspect around it.
Yeah, and we also we had a hub, and that particular one that we worked in was in Waterlooville, so we had this team of people phoning. But on the other side of the corridor, we had patients that were attending for face-to-face appointments. So general practice, I don't know if it must have been a national movement, stopped seeing patients face-to-face if they had any respiratory symptoms, and they would come to us. But again, I don't know how much we remember the PPE crisis, so no one had protective equipment, so there wasn't any protective clothing. And I remember, again, sort of reflecting conversation, I've worked in places where the sickness rate for staff is 0, even when they're in an Ebola crisis, because of the way MSF managed their PPE, and we basically replicated that model. So I worked with an amazing team of girls who engaged with a local haberdashery, and we manufactured our own protective clothing out of parachute material that we then tested at a lab. And our sickness rate from our staff was 0% during COVID, and that was before vaccinations. And yet there was other people that were sort of almost laughing at what we were doing, saying it was sort of overkill, and yet, but yes, it was a scary and fascinating time all at the same time.
Yeah, there appeared to be a lot of one-upmanship around that time, rather than listening to people who had the knowledge, which I sort of was aware that you had that. And actually, if you look at the statistics of what you did in that time with the clinic, there was essentially near enough 0 sort of COVID cases amongst your staff in that clinic. And obviously we know there's sort of things like COVID inquiries going on now and things, but it's interesting that they don't go into this type of detail, because clearly PPE, if there are future pandemics, is an important thing. I mean, how does that make you feel? Because I know that sort of gets into the politics of the NHS and obviously wider politics, but is that something that frustrates you? Is it something that you have interest in getting involved in?
Yeah, I mean, I think it's a discussion that I've had with friends and so forth about ego, and I think the debilitating thing about ego is how much it stops people from being able to actually succeed. I suppose I could, as an individual, be like, yeah, I told you so. But there were, that was the responsibility of the skills I've acquired over the years, of being able to share those at least with our local community and our local staff group, to be able to ensure that we're providing the safest care to people. how it works for the future, I suppose it is that thing about listening to people and understanding their skills, and a good leader, a good manager would make sure that they were listening to their staff and tapping into those skill sets, and also being able to admit, I don't know, and I think we're seeing that retrospectively. I didn't know what was going on, but actually if we'd have said at the time, I have no idea, there must be people out there that know. And unfortunately it would have only been a smaller subset, but they certainly existed.
Yeah, I mean, it would almost make sense to prepare for future pandemics to be on some sort of reserve list, because if someone like yourself has that skill set, historically and even through a pandemic, it's almost being a bit prepared for the future.
Yeah, and interestingly, I was in the Lake District in it must have been the first week of February, the year that the pandemic hit. And while so I was doing Ebola training, thinking that I was going to go onto the emergency medical register for the international community, and that's whether you end up in an Ebola crisis in Congo or earthquake in the Himalayas, whatever. And some of the international team were being pulled then and there. There was an Italian guy that just suddenly had to leave because the pandemic had arrived in Italy. So we all had our sort of wings clipped a little bit, and we're like, no, we're staying put in the UK, which probably worked out quite well for us. But yes, absolutely, we have them at international level, but we don't necessarily think about what we need at national level.
So obviously there was a pandemic, which I certainly felt a bit burnt out with. I'm sure you were probably more burnt out. And then, so after the Alliance, so that's probably talk about, what you've been doing since then, probably a little bit more about the now. So what are you sort of involved with at this moment?
So, absolutely right, after the pandemic I was very burnt out. So I took 6 weeks of swimming in the sea and running in the hills before planning my next move. So I decided to leave the Federation and set up camp with Laly's Pharmacy, where, they're a very forward-thinking unit, so probably one of the first community pharmacies that I'm aware of that's taken a risk to employ a nurse, and looking at things like clinical services that have obviously migrated from general practice and into the community pharmacy world. But we've always had this it's been in the background about what more we can do to support patients given that the NHS is crumbling around us. And that's how I've become involved in AccessU.
Because I think we both used to get frustrated with having limited control on things and influence, and sometimes being involved with the politics around sort of wider organisations when you go into general practice, what you talked about, and also the Alliance. Do you feel with what you're sort of doing now that you've got a little bit more of that autonomy and able to do things? And I know sometimes there might still be frustrations, but does it give a bit more satisfaction that you can see things happening?
Yeah, absolutely. And I think the interesting thing is being able to support the gaps, which is obviously the premise of AccessU. I am passionate about the NHS and people being able to access healthcare for free. I think that's an incredible thing that we as a country should be very proud of, but it's not working. So if we can provide some of the solutions, it's interesting the type of things that are coming our way at AccessU, but what's particularly nice is seeing it it's very results based, so we can see things building, which is nice as sort of latterly in my professional career, but also being able to, as you say, develop things that we want to, not necessarily feeling restrained or constrained all the time. The compliance element, being able to understand how we stay safe and how we offer the best practice and how we stay up to date and current is obviously a very real risk. But at the same time, if we're not wasting time or spending a lot of time on negotiating or asking constantly to be able to do things, then we gain in other ways.
And how have you found the pharmacy world? So obviously what you had been doing before was clearly non-pharmacy, and pharmacy is a different part of the NHS where they have their own contract and has its own trials and tribulations. How have you found that world? Because there are services that clearly you're sort of leading in there with sort of the Alliance Pharmacy Group. I mean, how have you found that?
Yeah, again, it's almost in sort of a deja vu kind of way. It was interesting what I mentioned earlier about nurses and doctors in general practice. Like when I arrived in sort of pharmacy world, I couldn't believe what silo working there was between general practice and pharmacies for the same patients. So I've been that patient that ping-pongs between community pharmacy and GP chasing prescription. So again, it's quite nice to bring some skills together to carry on networking with relationships we've already made through the federation and things, but also try and knit that understanding together between the various different clinical groups and clinical settings. Funding's obviously an issue, and I think it's, I quite don't enjoy being in a resource poor setting, but I've worked in resource poor settings all over the world, and I find it fascinating that I can get some drugs in South Sudan in the middle of a desert, and yet we're struggling, we're up against it in community pharmacy world. So it's really, really interesting. But again, we're also sort of, I suspect it's not a true, or not my perspective post-pandemic of community pharmacy is probably different to how the community pharmacy was before, partly because of HR changes, partly because of human behaviour changes as a result of the pandemic. So it's not easy.
And with your sort of involvement in the pharmacy world now, how do you find that they're obviously quite front line in what they're dealing with? How have you found that? Because I know that you've been involved in some sort of scenarios in pharmacies which sometimes can be tricky and things. I mean, has that been a bit of an eye-opener?
Yeah, I don't think your average Joe quite understands that the sort of vulnerability of the pharmacy. And I remember actually thinking that even before I'd witnessed anything that was going on, thinking, there's all of these drugs here, and there's an open shop, and there's a door that's constantly open. If you were a bank, if the pharmacy was a bank, glass doors and those kind of things. But like we've said before, it's also a business, so you can't have cage doors and additional lines of security, unfortunately. I don't think, as I say, the general public quite understand how vulnerable the staff are, how much they have to put up with. And that could be anything from just, a sort of entitled patient that thinks that everything should have happened yesterday, to some of the things we've seen in inner city Portsmouth with, urinating on floors and lobbing bottles at young staff members. And I don't know what the solution to that is, particularly.
Yeah, it's a really tricky one and a challenge for society at the moment, isn't it, in many ways. So you talked briefly earlier about sort of AccessU. I mean, can you sort of explain what that's about? I know it's something that we're both involved in, but it'd be nice to just see from
Yes. So AccessU is basically an independent healthcare provider, predominantly sort of when it was set up, it's predominantly for an independent GP services, as well as travel, vaccinations, and advice. And again, something that I particularly feel quite passionately about. I think when we sort of set it up, I had imagined a certain type of patient, perhaps women's health. I can always see a gap there, and tricky sort of accessing some of the sexual health services, women's health, contraceptive services, and so forth. And I just know that your average person has difficulty accessing GPs, but some of the things that we've seen coming through the doors has been really interesting. And actually, when I think about that in terms of justifying NHS services, it is quite interesting. So we've had a lot of medicals for HGV licences, for example, or I want to go on holiday but I've got a broken ankle, so fit to fly certificates, fit to do my job, whether it's HGV driving or there's a few medics coming through joining local organisations and so forth. So actually, are those sort of, should they be NHS services? So it is quite interesting, or scuba diving licences, all those kind of things. So really it was about being able to provide healthcare services that were going to enable people to look after themselves, but if that meant freeing up additional space in the NHS by what we're doing, it's a sort of a double winner.
Because both you and I are programmed for NHS, aren't we?
Yeah.
And obviously you've been involved in sort of lots of charitable things. How do you find, and I know we sort of are often challenged with the ethics around sort of private medicine and those sort of things, but how have you found that sort of transition, sort of accepting it? Are you seeing that there's a place for it in the UK? Because obviously the NHS is here, it's here to stay, it's wonderful, but with sort of people living longer and those sort of things, and our sort of access need is sort of changing. How have you found that transition? And do you think it's a good thing that things like AccessU could become more widespread?
Yeah, so, and I think that's a really important point about the ethics, because we do talk about that a lot. I think, as I said, the access point for those things that wouldn't necessarily need to be traditionally NHS funded. So, if you are going on holiday, then great, why should the NHS support that? What I think we don't talk about the amount of waste there is in the NHS. and all the while that we're sinking, I think we need to sort of focus on how we can be useful to those patients who might have, or those clients that might have money to be able to support themselves. It's interesting how people spend their money. I remember from ear irrigation in general practice, you know, people, that used to be a NHS funded service in general practice, and it was just deemed non-essential service, so it was pulled. In pharmacy world, we provide free blood pressure checks that are NHS funded, and we can't get people to take their own blood pressure, but people will pay to have their ears syringed. So it's just interesting where people spend their money.
Clean ears are really important.
Clean ears are really important. Doesn't matter about the tickets. But it's also interesting what people feel comfortable spending money on. We've seen a lot of weight loss injections coming through, or requests for weight loss injections, and again, it's for me, it feels very ethical as to whether or not we should be supporting, or are we doing the right thing. The need for a full consultation, I think really important that people are having the full sort of health check before embarking on that journey, and have they tried everything else. So I think there's a lot of, again, it's the post-COVID urgency, health seeking. I just want a quick win, and assessing whether or not it's we're sort of tapping into that too much, or whether or not we're actually supporting people with their health.
Yeah, I mean, what's amazed me with it from a personal perspective is it is almost mimicking sort of NHS GP, but it's just gone into private, and there's no type of patient that access it at all. All different. Is that something that you've sort of been surprised with, or did you sort of expect that?
Yeah, and it's interesting what you learn about your surroundings as well, isn't it? So when we built converted the clinic and sort of set up in Portsmouth, thinking about the demographic that we might see and who would pay within the city, with a very mixed bag of people, but actually it's also a very transient population. So we're on the coast, so we've got people coming and going from France. There's a lot of contract work that's going on down here, so we've seen groups of people coming from places like Wales, and I think there's a couple of guys from Belfast and those sorts of things. So it's been, again, because I like people and like diversity, it's been fun to see the different people that are coming through. But also interesting to think, actually we're really, really well placed. It's also really nice to dovetail with the pharmacies, so being able to offer additional services because we've got the additional CQC compliance, being able to support additional activities, which hopefully in turn helps support those separate entities as well.
And in recent news, fairly recent, the NHS England has been disbanded. What are your thoughts on that?
Did we get a time frame on that?
Well, I'm not sure. I think sort of maybe towards the end of the year, and apparently it's the largest quango. What are your thoughts on that?
Yeah, it's interesting how so many of these things go full circle, isn't it? I often think that with community pharmacy, how so much is coming back into the community pharmacy, and it's like the days of the apothecary, where everyone used to go to a little apothecary and get your healthcare advice. I think it's interesting. For me, it always felt like an additional unnecessary step to have, but it's what happens next, and sometimes what happens next isn't always any better. I'm hoping it will alleviate a lot of the bureaucracy and make things more direct, and hopefully from a commissioning point of view it will give a bit more power to the people that know how to spend that money.
Yeah, I suppose in current tough times economically, hopefully things get more efficient, whether that's from Department of Health straight to, I don't know if it's the super councils that come in, and then that's where the healthcare disseminates. That I suppose is the hope. And what about for you? What are your sort of future projects and things? I know you're sort of involved in sort of AccessU and things. I mean, where do you see sort of the future things that you're doing sort of going?
I do think sky's the limit a little bit, and it's just a little bit about responding to where the gaps are and what we could be doing. I think there's a lot of women's health stuff that we need to be looking at, so contraceptive services and things. Having some current conversations at the moment with various different people within the NHS about whether or not we can commission long-acting reversible contraceptive services to AccessU, because there is a gap there. We're collaborating with physios who are focusing obviously on musculoskeletal stuff. As you say, people are living longer, so is it about long-term health clinics as well as the sort of other bits and pieces like the travel medicine and so forth. I'm always up for either finding staff that we can train and develop, or learning new skills myself. So whether or not, whichever way, it's about responding to the need really.
Now the next question, you've been made the new health secretary, so not an easy job. What would be, if you were in that position, your top 3 priorities that you'd really suddenly want to get going if you were suddenly the health secretary?
That's a good one. So one of the things I haven't particularly talked about today is about the sort of my passion for developing staff, and I cannot believe how difficult it is for somebody of the right temperament, the right motivation to want to be a nurse. Equally, how difficult it is for somebody who was a nurse or a midwife to get back to retraining. Same, I'm sure it's the same in general practice, or doctors in general. So we've got a crumbling NHS with staff either leaving, trained staff either leaving and just deciding to become a florist or moving abroad to work, because we're just not looking at how we can support training and development. Funding's obviously a problem, but also sort of mentoring. We just sort of find someone go to a 2-day mentoring course and then look after this student nurse who's terrified, and people drop out before they've even started. So one of my priorities would be looking at how we can support the workforce. I also see, and again we definitely don't see it in AccessU or particularly in the community pharmacy, but maternal health is a huge issue. Well, I see a lot of maternal health issues in this country. We're really into intervention. We really, really love a planned C-section and a specific one due date where everyone thinks that that's when they should be giving birth, despite it being a 5-week period. I think there's a lot of coercive's the wrong word, but there's a lot of sort of informed consent that's being sold as informed consent, and mothers are actually making these really interesting decisions about C-sections or about being induced and those kind of things, where actually, again, probably as a result of stress or understaffing and those kind of things, not necessarily being encouraged to just birth naturally, and probably in a safer and less traumatic way. So women's health probably as a package, but including maternal health would be another priority. And then I haven't talked about it, but I'm part of a charity that looks at teaching CPR and defibrillator awareness. We have over 33,000 deaths as a consequence of cardiac arrest in the country. A lot of that, as we've talked about, could be managed upstream with things like hypertension management and those kind of things. But also, there's a lot of people that have heart attacks, go into cardiac arrest and end up in hospital for weeks at a time. From a human point of view, no one wants to lose a relative, but also from a funding point of view, there's so much money being spent on keeping people alive that have had these horrific incidents. And actually, the education around that, like teaching the general public how to look after their hearts, more focus on the nutrition side of things. Again, we sort of give 5 minutes, don't we? We say, just eat a few less carbs and don't eat takeaways. But sort of really, really robust dietary advice, as well as knowing how to carry out CPR, teaching that in schools and those sorts of things. So a big movement towards cardiac health.
Wouldn't it be better if we had a health secretary that could speak like that?
If you look at people like Jacinda Ardern, who was the New Zealand Prime Minister, who I absolutely loved, she used to, all of her MPs were midwives, teachers, they came from normal backgrounds, but it's like we said before, politicians in this country are politicians, they don't have a dual role, but actually we need human beings to be able to say, I think what we need actually is, X, Y or Z.
I'd certainly think it would help, or even if they had closer advisors like that. So if they're listening, you're around, aren't you?
Yes.
Not too soon.
We're doing things.
We're busy.
But that's been great. So I've learnt a little bit about you. So I've asked some questions. I hope that was okay. So it's good for you to be the first guest in the waiting room, and look forward to some future projects and maybe a second interview down the line.
Excellent.
All right.
An update. Thank you very much.